I'm John McKendrick. I've been asked to chair the event today, delighted to do so. So my day job then is to co-direct the Scottish Poverty and Inequality Research Unit. So what we're here to discuss today then, looking at welfare advice services and clearly the initiative that's taken place over the last few years and has been evaluated, is something that's absolutely central to the Scottish Government's mission to reduce, eradicate, make a difference to child poverty. Income maximisation, making sure that there's an increase in income from benefits is one of the three strands, if you like, that we are working towards to make that big difference by 2030 and beyond. So I've glanced through the report in the morning this morning, so I'm kind of primed up on what we're going to hear, but we're also going to hear from the horse's mouth then about how it's went over the last couple of years. The point today is to learn. We're not here just as a talking shop. We want to think about the relevance of it before we move forward. And it's perhaps a very apt day to be talking about this. We have been primed of tough times that lie ahead. One of our potential speakers, Neil Gray, can't be here because he's involved in the programme for government, which will be announced later today. And we've been told that means tough times, and that might impact upon the very service that we're talking about today in terms of how much we're able to invest in that in the years ahead. It absolutely will have an impact on the clients, and that we know if there's a squeeze in public services, then it's going to make life tougher for those that are already struggling, and perhaps will tip into the population of those that might not have been otherwise. The demand for that service will increase at the same time that service itself is perhaps being squeezed. And that makes it all the more important that we talk about the very best practice and what works and how we can make sure with the limited resource we have that it's working to best effect. And that very much is what we're here to do today. You've got a packed programme. We're going to do we'll hear from Neil Gray by way of video at the start. Then we'll hear from three presentations from Craig, Karen and Carey. We will have a short video after that, a YouTube video, and then we'll move to discussion. So after the three presentations, we won't take questions at that point. We'll have the discussion all together. We'll then have a very short comfort break, super short comfort break. And then we'll break up into discussion groups, two of which will be in here, one of which I'll explain to you at the time, one of which will move room, and we'll focus on two questions. And in those discussion groups then, there'll be a scribe, there'll also be somebody to facilitate the group, so all you need to do is sit back, put your feet up on the table and chip out your thoughts. We're not going to feed back in the discussion group. At the end of the day, that will be taken away, the improvement service will collate, and then we'll respond back collectively at the end. But Karen and myself will do some summing up at the end of the day, before which we will spill out into there and have lunch. By that time, we'll well and truly have earned our lunch after a good morning's work. So the point today then is to share thoughts, to be critically constructive, to learn, of course, and prime ourselves to make sure that we're making the very best of that resource as we move ahead. There is no fire alarm planned for today, so if you hear that, get yourself out there. Fire exit that way or fire exit that way. That was probably the quickest if we're in this room to get ourselves outside, and we will come together and make sure everybody's okay. And of course, I'm sure you know when you come in, the restrooms are immediately when you come in the door. So back out past the registration desk on the left-hand side if you need to use the restrooms. So without further ado, and challenging my technical skills, I'm going to hand over to Neil Gray, as I say, who's very apologetic that he can't be here today, but he took the time to have a short video message for us all.
Thank you for inviting me to today's event to share the findings from the successful Welfare Advice and Health Partnerships initiative. I'm sorry that I can't be with you today in person. However, I wanted to take this opportunity to share my reflections on this important work and the significant role you have all played in delivering accessible rights advice to communities across Scotland. Poverty continues to act as a persistent driver of health inequalities in Scotland, with the COVID-19 pandemic and ongoing cost of living crisis shining a spotlight on the challenges some of our lowest income households in Scotland face in this respect. So it is vital, therefore, that we ensure support is in place for those who need it, including access to advice to help people overcome issues which are having a negative impact on their lives, such as money concerns or debt problems. The Scottish Government is committed to ensuring that the way we provide information, advice and services meets the needs of the diverse population of Scotland. And as such, we have funded this Test and Learn initiative to support our collective understanding of the positive impacts of delivering household financial advice in a trusted and accessible primary care setting. And while providing access to rights, advice and GP practices may not be a new initiative, Scottish Government funding of over £4 million since 2021 has allowed us to test the effectiveness of this approach at a national level for the first time. And I've been struck by the positive impacts of this work. And while others will provide details on the findings from the evaluation, I wanted to take this time to share my reflections. It is clear that the welfare advice and health partnerships model of advice is enabling more people to engage with the support that they require. By making advice services available in a trusted setting where people already go, more than 16,000 individuals across underserved communities in Scotland have accessed vital information about their entitlements, resulting in financial gains and improved health and well-being. A key assumption at the heart of this model is that providing access to advice in a non-stigmatising and accessible location will mean that we reach people who may have previously been distanced from traditional advice services. And this is borne out in the findings from this evaluation, with over 89% of people accessing advice for the first time through an embedded partnership. Making sure that people in Scotland are aware of and encouraged to access all of the financial support they're entitled to is a fundamental priority for the Scottish Government. Our benefit take-up strategy is aimed at making sure that money ends up in the pockets of everyone who is eligible. It is extremely encouraging, therefore, to see the significant financial gains that people have been able to make by being supported to take up their social security entitlements. It remains an unwelcome reality that communities in Scotland experience health, quality of life, and even life expectancy differently, depending on their circumstances. As the Scottish Government, we recognise that tackling the root socio-economic drivers of health inequalities is required to stem the current tide of unequal population health in Scotland. I was therefore heartened, again, to see that alongside the financial gains made by service users, positive health impacts have also been reported by those receiving support through a welfare advice and health partnership. Similarly, participating GP practices have also noted improvements to the way that they engage with and support their patients. This model of advice provision therefore serves a dual purpose, reaching people who have not engaged with traditional advice services and reducing time spent by GPs and others, clinical staff, on non-clinical matters. There is no substitute for accredited welfare rights and debt advice, and this is reflected in the findings from the evaluation. In recognition of the vital role of household financial advice, the Scottish Government has allocated over £12 million this year to support provision of free income maximisation, welfare and debt advice services. This funding is supporting a range of services and advice providers, including a contribution to the funding of welfare advice and health partnerships this financial year. Upon taking up his post, the First Minister set out 4 overarching priorities for his government, and this includes improving public services like our NHS and eradicating child poverty. Initiatives like welfare advice and health partnerships are examples of how, by working together at a local and national level, we can make progress in delivering on those shared missions. We know that advice services are critical to Scotland's communities, supporting people who may be struggling financially to navigate available payments, grants and benefits. As the Scottish Government, we're under no illusion that we can maximise incomes alone, and we are grateful to you, our partners across the public and third sector, who work tirelessly to provide essential frontline support to people up and down the country. And as many of you today will be aware, the Welfare Advice and Health Partnerships Test and Learn period concluded as anticipated in March of this year. However, in recognition of the positive impacts of delivering advice through this model, and because of the effective partnership working, joint investment with local authorities is facilitating continued service delivery this financial year. By combining Scottish Government and local authority support, together we are placing welfare rights advisors in over 160 GP practices across Scotland, supporting those most in need to access advice to maximise incomes, improve well-being and help people to live healthy and fulfilling lives. The financial pressures we face at a local and a national level are stark, and we are under no illusion that difficult decisions will need to be made in the future to target support and resources. Ongoing economic constraints continue to apply incredible strain on advice services and the households that rely on their help, on your help. So we are committed to working with our local authority partners to ensure that resources reach those who need it most. To build on the successful outcomes of the welfare advice and health partnerships work, we have allocated up to £1.5 million this year to increase provision of advice services within other services that all people already access. Our Advice in Accessible Settings Fund is supporting a number of projects across community-based services, housing and homelessness services, faith-based charities, specialist mental health services and carers support services. So we'll continue to complement our efforts to tackle the socioeconomic inequalities that are at the root of health inequalities with a range of cross-government action. Alongside welfare advice and health partnerships, this includes our ongoing support for more than 300 community link workers. Community link workers offer one-to-one support to patients, similarly reducing pressures on GPs and bridging the gap between general practices and communities. To ensure effective delivery of the service, we have commenced a national review of this policy, drawing from the voices, experiences and insights of community link workers to help plan for future policy development of this incredibly valued service. We are supporting the ongoing development of primary care multidisciplinary teams, including link worker services, through investment of £190 million this financial year through the Primary Care Improvement Fund. However, we know that building a healthy society requires more than just national action. Driving change at a local level will be critical to reducing health inequalities. So to conclude, I want to thank you all for the important role, the critical role you are playing in delivering welfare advice and health partnerships. To our partners across local authorities and health and social care partnerships, third sector organisations and the welfare rights advisors providing this invaluable support, we would not have been able to deliver this initiative without your collective contribution and engagement in this process. In addition, from the outset, the Improvement Service, together with Public Health Scotland, have championed this work and have been critical in ensuring its successful delivery. This has been a truly collaborative process which has and is continuing to make a real difference to the lives of the people of Scotland. Thank you.
That was very welcome that we got that introduction by Neil, he said. Well, you've listened to an academic and a politician and we're still on time, so I think that's certainly positive on the lies ahead. But now we're going to hear, if you like, from the horse's mouth, Improvement Service from Karen, from a GP perspective from Carey, and then from Craig from an advice service. 3 presentations to give an insight and overview. As I say, we won't take questions at the end of the presentations. We'll show a short video and then we'll move into questions after that. So please ready yourself by taking notes of anything that you want to ask. And when we get to that stage, if you can just introduce yourself, who you are and where you're from, would be very helpful. Now, I am not a role, so I'm going to move my chair so that I can go around and I can see the slide on top of the screen. I'm going to do that. Can I invite Karen to come along and give us a first presentation? Thanks, Karen.
So I'm Carrick and I'm the Evaluation Programme Manager Improvement Service. This programme has been managed really by a team at the Improvement Service. I can't claim credit or blame for it alone. The other members of the team are up there and you'll meet them in the course of the day. But there are other people that I want to acknowledge who perhaps don't work for the improvement service but who've been involved in this process. Obviously, all the advice providers and advice agencies, it's been great working with you, and I've really got to put on record our appreciation for all your efforts and all the support that you've given us in what has sometimes been quite difficult situations. But there are another two members who work for Scottish Government who have also been instrumental in helping us deliver this programme. Now, one of them is here today. Francesca, do you want to make yourself known to the room? The other one has sadly moved on. Now, I don't mean he's no longer living. He's moved on to another area of Scottish Government, and that's Rory Sutherland. Now, both Rory and Kate Burton, who's mentioned there, they really are responsible for developing this programme, and it's thanks to them that we managed to get this investment in advice services. So can I ask you to show your appreciation for Kate Burton and the absent Rory Sutherland? Right, that's enough of the clapping now. Let's move on. So, the improvement service, I don't know if everybody in the room knows who we are. We are a part of the local government family. We work extensively with local authorities, health and social care partnerships and community planning partners and Scottish Government. And they're a range of the activities that we deliver. There's far too many to fit on one slide, so that's just really a summary there, that we deliver national improvement programmes, we provide evaluation, community and research services, and we also have national shared service applications and technology platforms, My Account, the under 25 card, under 22 card, loads of things like that. And we also work extensively to provide leadership on improvement and transformation with local authorities. We do briefings for elected members, for example. So we do a load of activities. If you want to know more, have a look at our website. I've got to stress from the outset that this session today is looking at the original authorities that participated in the WAP programme. So they're the original authorities that was agreed to participate. As you may know, the programme was extended and that to include local authorities or health and social care partnerships in rural and island communities, and they're not included in the information that I'm going to give you today. So what we're focusing on today is the 2 years funding that was used by these authorities. Okay, so I want to say a wee bit about the evaluation process. Now, this was a test and learn programme. So because of that, we did probably ask for more reporting than would normally be expected. And that was really just to prove the benefits of the programme, that who was accessing it, why were they accessing it, and what benefits were they getting. So to do that, we did some quantitative data collection and some qualitative data collection. Each advice provider was responsible for providing a quarterly report that covered a range of metrics. So things like demographic information, number of people, financial gain, reason for seeking advice, referrals in the GP practices. Some of the people in this room will be painfully familiar with the breadth of information that we requested, and which, as I've said, we're very grateful that we got. So we had them on a quarterly basis, and we've been able to analyse them in some detail. But we also had qualitative information. So we did some customer journey work. We did a survey of GP practices, and we got over 220 responses, which was really good. We had discussions with the local authority advice leads. And because of that, we were also able to capture their perspectives, and they shared with us some case study examples of individuals who benefited. And those case study examples of the individuals, I think, really bring to life the benefits of this approach to delivering advice services. Having said that, we're now going to go on to the boring stuff and all the stats. So, one of the big benefits of delivering advice services in this way is that it's people who would not normally access advice services. So we are able to demonstrate that 89% of the people who are accessing advice services through GP practices have not previously accessed advice services. So it shows that it's really engaging with those people who really do need advice, but may not be otherwise able to get it. I've mentioned the sort of quantitative data that we got. We looked at a range of measures, one of which was ethnicity. Now, it'll come as no surprise that the majority of people who are seeking advice were white, came from white background. But it should be borne in mind that 7.1% of Scotland's population come from a Black minority ethnic background. So we are able to reach BME groups through delivering advice services in this way. There's also, and there's a bit more detail about this in the report, that the ethnicity of an individual really has some influence on the type of support they're seeking and the type of benefits that they're claiming to a limited extent. We also looked at household composition. What I would say with this is that, again, in common with most advice services, it's single adult households who are seeking advice. And it may appear that families with children are seeking advice in this way disproportionately lower. They are getting advice support higher than would be in our sort of normal setting. We can show that. But what we'll have to take into account with this is that in Glasgow, who have half the GP practices, they make referrals using a different route through Healthier, Wealthier Children. So we're probably not picking up all the people who are seeking advice that have a family. But despite that, you can see that families are being able to access advice in this way. Perhaps not surprisingly, almost half have a disability or long-term condition, and that's fairly obvious. You're providing advice in a GP practice. People are going there because they're ill, so or they need their health attended to. So again, it's targeting that particular group. What we also looked at was, well, what were the economic status of people who were seeking advice? Again, it was almost 60% were economically inactive or long-term sick or disabled. Now, when we say economically inactive, that could also be people who are just off sick short-term. And I think a fairly substantial percentage of that fell into that category, and we can show that by the reasons that people had for seeking advice. Housing status, again, over half were tenants and local landlords. Interestingly though, there were some owner-occupiers. They accounted for about a fifth of the people who were getting advice. Household income is probably one of the things that is of most interest here. If you look at the household incomes of the people who are actually getting advice, over half have less than the national minimum standards for recommended for income. So it's targeting people who are the poorest and most vulnerable in our community and enabling them to increase their income. There were a few who had higher incomes, but you can see very, very small majority. The focus very much is on people who are living or experiencing poverty. So what we also looked at is why were people seeking advice? Who was referring them for advice within a GP practice? So if we look at the first of those who's referring them within the GP practice, it was by and large community link workers, who accounted for almost half. And over a quarter were GPs. Now, I would say that this doesn't quite tally with the results that we got for the GP survey, but the GP survey was a smaller population size, and I think a lot of that depended on the nature of the person who was filling in the returns for us. Having looked at who's making the referral, why are they seeking advice? You can see overwhelmingly 3/4 it was suggested by practice staff. And you've got to think if that suggestion hadn't been made, the chances are that person would not have sought advice. Other factors were confidentiality. Now, we asked people to identify the factor. So it could well be that it was suggested and it was confidential service. But what we wanted to do was identify what was the primary driver for this. But we also wanted to look at, well, why? Why do you think you need advice? In general terms, we know you're getting it in the GP practice. Why do you think you need advice? And the majority, about a third, were unable to work for health reasons, which goes back to that other slide where we were talking about the condition of people who were seeking advice. So a lot of it could be that they wanted to get back to work, or they could be genuinely that the longer term they needed more support. Struggling to pay bills, help with claiming benefits, able to cope financially. Again, those are the kind of reasons that people had. And we asked them again to give primary reason for seeking advice. The appointment types, a lot of telephone appointments. You've got to bear in mind that perhaps the first appointment could be face-to-face and subsequent appointments could be telephone. But I think this just reflects what's happening in GP practices now, that what we said to the individuals who were participating is provide the same service in the same way that GP practice is providing it. And in GP practices now, it's a lot of telephone appointments. Financial gain by benefit grant type. Now we can actually break this down, as I've said, by some of the demographic characteristics that we've got, and that's covered in the report. But again, the main one is adult disability payment. Interestingly enough, the universal credit features quite prominently there as well. But majority, if you look down all the benefit lists, the majority are associated with ill health or disability. In terms of debt type, again, council tax arrears were the most common one reported. What I would say with this is that we were primarily interested in the type of public sector debt that people had. So there was no requirement to complete this for all the different debt types. But you can see that council tax arrears, as we all know, remains an issue for people. So I talked about the quantitative data that we collected, but we also did some quantitative data too, and we did some customer journey mapping. Now, I've got to manage expectations here. We had hoped to interview more people. We will do that in our next report, but the results that we have are for the 28 people interviewed across 5 local authority areas. The demographics, again, it's probably slightly skewed in towards the older age group, and it was mainly single people or adult families. So bearing this in mind, what we did with them was we mapped their customer journey. Now we looked at what were the main point each stage of the journey, from people's initial reasons to seek advice, through finding out about how they actually found out about advice, being referred to the advisor, their experience of the appointment process and getting advice, to their feelings about the advice in general terms. But what we wanted to focus on was their health, because we recognised that there was a gap in the research here. We didn't really know what was happening in terms of people's health. So this is based on individual perception. Okay, it's not based on accessing medical records. But you can see from that people's anxiety levels were better. They felt less depressed, fewer panic attacks, less stressed, less insomnia. Physical health, people, were more ambivalent about that. They hadn't seen the same benefits to physical health. But I do think you've got to consider that if somebody has a long-term condition, Carey will speak more about this than me, you're not really likely to be able to improve their physical health in the short term. So we asked people, well, what's your view? What do you think? Do you think this service should be available? It's in your GP practice, should it be in them all? And they all said, yes, no surprises there. And the reasons that they gave were there. The effect on them, it was accessible and convenient. They trusted the GP and the practice team, and they felt it offered support that was comprehensive and effective. And there are a couple of quotes from individuals. I'll just give you a few seconds to read that. So I mentioned the GP practice survey results. I'm not going to go into them in detail. There is more information on our website, and I know that Carey's going to pick some of that up. The only thing I would say is that what is interesting is that GPs recognise that it saved them time. So it varied, but most of them, it was in the time saving of 30 minutes to an hour a week, which doesn't seem a lot, but does equate to about 3¼ days a year, which in clinical terms and pressure on GP services is quite important in the current context. We also looked at, and it was mentioned in the Cabinet Secretary's address, that the role with community link workers. Now, we consider that in some detail in the report, and think when it works effectively, it's brilliant, and we can make referrals, but it doesn't always work effectively. And I think we've got to recognise that. So what really I want to do is to set the context and distinguish between. So community link workers are a generous role. They're also called community connectors sometimes because they connect people to services. They work collaboratively with patients. They identify issues that affect their ability to live well. Welfare rights advisors is a specialist role. They should be regulated and accredited, and they provide patients with social welfare legal advice. And I know that Roddy, who did some work on this, talks about if you're in crisis, no money, you don't know how you're going to pay your bills, you're not really thinking what's out there in the community that I can access. So the welfare rights advisor has that immediate help to get people's finances sorted out, to get them in a good position where they can then move on to look at what's happening in the community and how they can improve their health that way. The lessons learned were that when we look at this in the round, were that you needed clear leadership on a local level from somebody who knew what community link workers did and knew what welfare rights advisors did, so that they had that understanding and they could explain to everybody the differences and how they could integrate. That was really important because sometimes that message, people didn't always get it. Some GPs didn't want to take part in the service initially because they thought it was going to create more work for the GP, whereas what we've demonstrated is actually it saves them time. So this kind of agreement, once you've got your trusted intermediary who can explain things, what you then need is some sort of agreement or some sort of principles so that both parties understand what the other one is doing and can work together on that basis. So in terms of overall the project, we talked advice leads because if this is to be rolled out nationally, and it would be lovely if it could be available in every GP practice, what are the barriers or enablers to expansion? So securing agreement from the GP practice to participate, that could be quite challenging because unless there was that trusted intermediary, there was that kind of lack of understanding. Well, I've worked in lots of different sectors, and each sector has its own language, and advice workers don't always have health speak. So it helps if somebody can actually communicate with GPs in a way that they understand. And it also helps if there's a GP who will go along and talk about the benefits of this approach to service delivery. That can be quite time consuming and it can be quite complicated. So having people on your side who can get in there and make things happen is really important. Becoming embedded in the GP practice, that can be difficult too. There's space. Not all GP practices have accommodation. And as more and more services are put into GP practices, that can be harder as well. And one authority talked about, well, the GP, they're not in the practice that much now. So how can we tell them about it when we don't really see them very much anyway? And also having a good referral process, an easy referral process. Now, everybody uses slightly different referral processes, but the ones that are probably more effective are when the admin staff in the practice can just make an appointment and there's no form filling and there's no complication and going through lots of different stages and lots of different people. So that's important to consider too. So really, I've talked here about having a champion, that's essential. Other issues that came up were the data sharing agreements, and I think people felt the pain of that, particularly if central teams got involved, maybe if lawyers got involved, then it really complicated matters. Sometimes it was more effective when a local agreement that met both parties' needs could be developed. Recruitment was an issue as well. These are short-term contracts by and large. There are a limited number of welfare rights advisors, so recruitment could be quite challenging. And obviously the budget pressures that we've all learned more about this afternoon. So in conclusion, this is really just a summary of it. 89% of individuals accessing advice in their GP surgery had not previously sought advice. 16,000 individuals used the service during that period, and they made financial gains of 23 million, which now in the whole programme, £4 million has been invested, but the investment for the period that we're evaluating here isn't 4 million. So, bear that in mind. 38% sought advice because they were unable to work for health reasons. 22% needed help with council tax. Now, can anybody spot the deliberate mistake in the last line? So it should be at less than 20,000. Okay, no, yeah, there's a nothing missing. So apologies for that. It is also sadly in the report that you're about to receive as well. So what I want you to do when you get your report is take a pen and change it. Okay, that's your task for today as well. In terms of health benefits, 98% of staff, almost everybody in GP practices thought that the approach offered multiple benefits to both staff and patient. As you have said, 75% because it suggested improvements to health, and 50% had a disability or long-term health condition. So I suppose in conclusion, what I would say is whatever individuals' roles were in this, they thought it was positive, they thought it was beneficial, and they wanted it to continue. So fingers crossed. Thanks very much.
Thanks very much, Karen. So an overwhelmingly positive overview then of the programme over the last couple of years. As Karen mentioned, the report that you're getting today is an interim report. A final report will follow in the autumn, and that final report will also incorporate the rural areas. Of course, there will be some rural areas within the largely urban authorities. There'll be some rural perspectives to glean today, but the specific rural issues will come through in that final report. So we've heard from evaluation. We now move on to two different perspectives of participants, one from GP and then move on to advice services. The two finest cities in Scotland are represented here in Glasgow and Dundee, and we'll kick off with Glasgow and Carey. With apologies to people from Edinburgh.
Good morning, everybody. I won't actually say that I'm a Lothian GP then. Anyway. Dirty word, obviously, but it's lovely to be here. Thank you for inviting me along. My name's Carey Lunan. I have been an NHS GP for 20 years, and I've had the joy of working with two welfare advisors during that time in homelessness and in a deep end practice, one of whom is here today, Michelle. So it was really very lovely to see you. So I'm going to talk a little bit from a clinical perspective about the impact that we have seen working with you amazing people. So just moving on to just say a little bit about the Deep End. You probably have heard of it, I imagine, but Deep End Group was set up in 2009, and it comprises GPs working in the 100 most deprived areas across Scotland. So that's about a tenth of practices across Scotland. The graph shows the numbers of people living in the 15% most deprived postcodes in Scotland, and the line is a bit of an arbitrary cut-off, but to the left of the line are the deep end practices, 100, and to the right are the non-deep end practices. And I think that's quite an important graph because what it also shows is that the majority of people living in poverty they're not actually registered with a deep end practice. So poverty is across the whole of Scotland. Every single practice has patients experiencing poverty. We shouldn't think of it as a special interest topic. I'm largely saying that to appeal to my own profession, but there are particular challenges, no doubt, in the deep end where poverty is much deeper and much more acutely felt, and most people are experiencing it. So this is just a slide capturing what some of the issues are for the communities that we're caring for. The ones on the left you'll be acutely familiar with because these will be the issues that you will be discussing with people when you see them, and the ones on the right are the challenges that we face often as clinicians working in the deep end, just the levels of need, the levels of demand, the smaller numbers of workforces, the shorter appointments, and all the issues around health literacy and enablement and empowerment. So it's challenging but rewarding, but not an easy place to be living. Health inequalities, as we know, are driven by lots of different factors, and this man is quite a familiar figure. So 40%, of course, being driven by social and economic factors, but also health behaviours, the places that we live. But 20%, this is what I'm most interested in, are driven by healthcare. So access to high quality healthcare isn't always as good as it should be for the people that need it most. Sometimes something called the inverse care law, and I'm really interested to think about how healthcare could be the very best it can be for the people who need it the most. And of course, we know that Scotland's health inequalities are not good. We're top of the table for a number of things that we don't want to be the top of the table for. We know that the gap in healthy life expectancy between the most and the least affluent populations is getting worse. And of course, health inequalities is all through government policy. It's in the CMO report every year. This is the CMO report from 2 weeks ago, where the point is made again that health inequalities are really closely linked to income inequality, and that this is getting worse and has adverse health impacts through food insecurity, fuel poverty, housing insecurity, transport poverty, and reduced social support and interactions. We know all of this stuff. The time is now, I think, to think about what we do to upscale it all. And I'm just sharing this slide because it's very stark, but we know that there are very, very close links between poverty and disease. There is virtually no health condition that isn't made worse by being poor, just in a nutshell. And this quote from the Health Foundation tells us that in terms of people dying young, those living in the most deprived fifth are at least as likely to die from almost every cause. So cancer, long-term conditions, every single cause, and for some outcomes, such as the so-called deaths of despair, those that are driven by mental health problems, addiction problems, these inequalities are far greater. So it's pretty stark. And we know all this, of course, because these are the people that you're seeing. But put simply, poverty kills. So I remember many years ago, I was doing a presentation down in London, actually, at a BMA conference, and it was to a patient group. And I was asked to speak about what is the role of doctors in addressing health inequalities. And I was talking a lot about our role as advocates and lobbyists and various other things. But the thing that kept coming back to me was that actually what we often feel when we're consulting is you just need more money, because without money, you have no dignity, you have no choice. You're very restricted in the things that you can do, and I am over medicalising what I am hearing from you in terms of the impact that poverty is having on your life. What I wasn't aware of at that particular point was that there was a pilot project going on in Glasgow, which many of you will know about, of course, in 2015, within 4 practices in the deep end, where welfare advisors are spending half a day a week embedded in teams, working with patients who were experiencing health issues due to financial difficulties. And of course, the kind of findings from that, I guess, are now written into history, but very, very significant return on investment. And as Karen was saying, the vast majority of people being seen had never seen people for money worries before. So some really important learning there captured in these 2 reports, which have got the embedded links at the bottom. And I'm very happy to share these slides if anybody would like them as well. And some of the things that made that model work were that working in general practices was where you got population coverage, where there was cumulative knowledge of patients over time, where there was access to clinical records, so it made form filling easier and targeted support easier, and continuity of contact with patients across their life course and when they were engaging with the benefit system. And of course, what we know is that the inverse care law also exists in terms of people being able to access support with money. So the largest concentrations of patients who were needing help with their money were also found in general practice, who were least able to take on the additional work. So this felt like a bit of a no-brainer, if I could use that term, in terms of matching these 2 really important services to address unmet need. And of course, where are we now? I don't know if this figure is entirely up to date, but many more than there were in 2015 in the most deprived areas largely, but also in rural and island settings, with often referral and self-referral processes and practices giving advice over a wide range of issues. And that was my colleague from Carrick when I was a partner there. So getting on to the meat of what I wanted to share with you today, what it means for us as clinicians to have embedded welfare advisors in our practice. Well, I think the first thing for me is that it enables us to think more holistically than we can if we have only got medicines and prescriptions and medical advice at our disposal. So I think we would often, before this service was available, over-medicalise the impact of poverty because we didn't have anything else that we could offer. So I would find myself with great frustration and sadness prescribing anxiety medicines because people couldn't sleep because they couldn't pay their bills, or prescribing food supplements because people were underweight because they couldn't afford food, or prescribing pain medication because people couldn't afford to get out and walk or get access to things that would otherwise help them with pain. So it massively over-medicalised what was essentially a social problem. So it also made us feel more able to ask the question about money. It's hard to ask a question about something that you can't then give support for, because you feel like you open a can of worms and you create expectations and then you have to let people down. So I think people would often feel that they just didn't really want to go there, partly because they didn't have support that they could offer, and partly because we don't really have the knowledge to be able to advise on what happens next. So having a member of the team who's got this expert knowledge that we can just link into is absolutely fantastic. It helps us learn, but it also gives us confidence that we can link somebody in with somebody who does know the advice to give. So I think this whole sort of experience of both working with you guys and with community-led workers have encouraged general practice, particularly in deprived areas, to think about what does a team look like that builds social inclusion. I'm really interested in that as a chair of the deep end. We're moving away, I think, which is a good thing, from teams that are traditionally about doctors, nurses and receptionists to teams that are about community link workers, welfare advisors, community connectors and other third sector groups coming in to be co-located in our surgeries and thinking about health in a much bigger way. So it helps us, I think, build relationships of trust and understanding with our patients, because being able to ask about money and recognise and validate that their poverty is impacting on their health and that it's not their fault, I think helps to build trust with people and helps people feel like they can disclose things that they're worried about. And it also empowers us to lobby and advocate on behalf of patients as well, and on behalf of the service, so that we can see it more widely rolled out. And of course, yes, Karen mentioned it also gives us more time to deal with clinical issues, as you've mentioned before, which is always going to be welcome, of course. And just thinking more generally about this concept of what we can do as general practice and what can we do within healthcare to make sure that our services are as good as they can be in the areas that they're needed the most. We had a discussion at the end of 2022. Roddy was there. I think Roisin, you might also have been there. And it was a deep end steering group roundtable where we talked about what can general practice do to mitigate the cost of living crisis. And it was just thinking about, yes, there's all the health stuff, but there's also all the other stuff, which I just talked about there. We thought about what are the specific challenges and what are some of the solutions to these issues, one of which was we need to see much more support for the social support roles and practices. So again, that report has got an embedded link at the bottom there. And some of the things that came out were we need to build these teams that promote social inclusion. We need to really maximise this community hub function of general practice and all the links that we have to the wider health and social care system, but also the third and voluntary and charitable sector. And we need to get good at being able to effectively and sensitively share practical resources for patients that are about making them feel more socially connected, more socially well and more medically well. And in addition to that, think about how can we effectively advocate and lobby on behalf of the people that we care for. So Karen's talked a little bit what it means for patients, but I think the things that really stand out for me is that it reduces shame in talking about money, and it reduces the stigma that maybe people feel because it's felt like it's part of a healthcare in its widest sense set up. So I really feel that that's an important thing that has been enabled with these models of embedding in practices. It also, the statistics are stark, has massively improved access in a way that maybe we wouldn't have predicted, but people who'd never accessed services before feeling able to go and see someone who's part of a trusted team in a trusted location and not having to travel across the city. We also hear about the practical supports that that people are given to deal with financial stress that is just directly impacting on their health. We also know that people will appreciate the ability to speak to someone, and whether that's on the telephone or in person, but digital exclusion is a huge issue across lots of different services at the moment, so being able to meet with someone has made a massive difference. And also just going back to that thing that I said at the beginning about offering more dignity and more choice about what you want to be able to do for yourself is really powerful as well. And that's just a quote from the 2017 evaluation, which pulls out a lot of those themes as well. These are just some quotes that I'd collected when I was preparing for this today from a community link worker colleague that they'd received as part of a local evaluation. But again, it just highlights a lot of the things that I've said around access, being put at ease, inclusive services, flexible services, all the things that we know make a difference for people being able to get the help that they need. And what does it mean for our teams? So I'm really interested to think about how it empowers not just GPs, but the whole of the general practice team. So I think there's an increasing interest and an increasing recognition of the value that teams hold in being able to feel empowered to be able to support people in the issues that are impacting on them, particularly in deprived areas. So the whole team can be trained up and enabled to support social needs, to be able to do effective and sensitive signposting to different parts of the team, to be able to take responsibility for keeping a practice website up to date, and also having social supports on there, having posters in the waiting room, having stuff on the screens, and being able to link in with a colleague who can offer more practical social support is also just really powerful. And I think it was the third biggest bar on your chart around where the referrals were coming from was coming from receptionists. And just, again, these are just examples of links that can be put on websites. But if you've got social supports right up there with how to order your repeat prescription, it just destigmatises it because we consider it as a part of healthcare. This is just one of the posters that a colleague shared with me from Carrick medical practice in Glasgow, and right down in the kind of bottom right-hand corner, money worries affecting sleep, don't worry, we've got a welfare advisor that you can speak to. So it's just thinking about things in a holistic way and having the information really visible, really accessible in our waiting rooms that I think makes a difference as well. Now, I'd asked colleagues for some case studies and I was inundated, so I've picked three. And this one is from a deep end community link worker where most of the referrals come from, and this was a very powerful one of a 64-year-old man who'd been referred in, had had 2 cardiac arrests at home, and that to me was quite astounding because he was still alive. Chances of surviving a cardiac arrest at home are not high, but his wife and his son had performed CPR and he had survived, and all he wanted to do was get back to work. He was a chef, he'd just taken on a new job, he'd just taken out a new mortgage, he was 64 years old, and he just wanted to get back to work because he believed that he wasn't eligible for any benefits to support him to maybe not be working at this point in life after very major medical issues. So he'd spoken to a community link worker who linked him in with the practice welfare advisor, and the support that he managed to get was phenomenal around the benefits that he was eligible for. His mortgage was paid off with insurance that he didn't really understand and had difficulty claiming. His road tax was paid, and his wife also got support for the caring role that she was taking on and the mental health issues that she was experiencing. So a real joined up way of being able to support this family so that he was able to retire at the age of 64, which is really what he needed to be able to do. And he felt he'd been given a second chance because he was worried that he might have another cardiac arrest, which is probably pretty high possibility if he'd been carrying on that way. Welfare advisor at the deep end shared this with me. Again, just thinking about the issues that are presented are very different from different demographics. A 16-year-old Romanian woman recently had a baby, socially isolated, limited English language. We know that in the more deprived communities, they are also often more multi-ethnic communities, and often we need to go work through translators, which can be challenging to do well. But with the aid of a translator, the welfare advisor was able to make liaisons with the Home Office and with the benefits system and get her much less socially isolated and much less financially stressed. And then the third one was from a deep end GP. That's slightly gone a bit weird on my slide and on yours, sorry about that. A young man who had a prepayment meter and wasn't able to have enough money to get the heating on at the weekends, which meant that his children were struggling to come and stay with him. So he was losing contact with his children. They were losing contact with their dad. Their routine had been disrupted. The family dynamics were difficult. His mental health was impacted. His ability to work and function were impacted. It just had all these ripple effects. And being able to see the welfare advisor to get support on those things was what turned it around for him. And the GP that shared this with me said that this is the case that kept her awake at night for weeks. So although it doesn't seem like much from how I've written it down here, it was very, very distressing to hear about. And the fuller version is on our link there, the stories from the front line, which was a collection of case studies that we put together with permission from patients when we did our deep end report on the cost of living crisis. It's on our website. So we thought about what next. I guess you've said a lot of it, Neil Gray said a lot of it, but thinking about sustainable long-term funding has to be up there. Upscaling of existing provision, because, you know, thinking beyond the deep end, just going back to the slide at the beginning, we know that patients experiencing poverty are located all across Scotland, but also just thinking about how we can make sure that jobs are attractive and secure, and don't have all the stress around not knowing how long the funding is going to last for. We would like at the deep end to be able to lobby with you on that, so please let us know what we can do. And this is just another quote from a deep end GP about recognition of the huge rise in workload that is coming into welfare advisors, particularly during the COVID pandemic and the cost of living crisis, but worries about the impact that this is going to have given the capacity of the workforce and the difficult things that are to come. So we feel at the deep end, and I know beyond, that the colleagues offering social support to improve health, such as yourselves, community link workers, really now have to be considered as a core part of modern, inclusive and equitable general practice. And I just wanted to finish, if I can, with a 3-minute audio from a patient called Jenny, who wrote a case study for us during the cost of living collection of stories, and she recorded a shortened version of it for me because she can make the case far more eloquently than I can for the need for having good access to financial supports. I'm hoping this is going to work without too much echo.
When people talk about the cost of living, they talk about fuel poverty and food poverty. But what does that actually mean to the average person? So I get paid every second Tuesday. I spend over 35% of my benefits on fuel. They say if you spend over 10% of your money on fuel, you're living in fuel poverty. So what is my situation then? And even though I use over a third of my benefit for this, I spend approximately 3 days before I get paid with no heating or hot water. In general, my gas cuts out on the Saturday night, and I am left to the Tuesday morning to cope with this. The effects on me are far-reaching. I have chronic psoriasis. Not having hot water means I cannot clean my skin properly. I use boiled kettles, but I need several to wash my skin. Even though I try to keep up with this routine, whether I have hot water or not, the fact is, there is nothing more depressing and challenging than facing a freezing cold bathroom and trying to be thorough with my skincare 2 or 3 times a day. The fact is, my skin has been getting worse over winter, and I am now battling daily infections and escalating painful weeping sores. So much so, I now have had to be referred to dermatology. This is a prime example of how the cost of living directly impacts the NHS. All those boiled kettles are only adding to my electricity bill. This is continually impacting my mental health and well-being. I use the kettle to do dishes and to clean, again costing me several pounds a day. Then I use a small electric fan heater, which is really expensive to run and less than effective at keeping out the cold. My house is becoming damp, cold and very uninviting. I have lived like this before, but I had some understanding of why I did. Chronic addiction saw me without heating, without hot water, electricity and food. I am now over 3 years clean and sober. I do not understand why I am having to live like this now. With over 35% of my benefits going in fuel, I am struggling to spend anywhere near the amount I need to feed myself and my partner Steph. I cannot afford a big shop every fortnight anymore, so with choices limited, I have got into the very bad habit of shopping on a daily basis. Often Steph and I have to meet after our days are done and count out how much money we have between us before we decide what we can afford to eat that night. Feeling hungry going to bed, trying to get to sleep, was a thing I thought I had put behind me in life. My point is that it's not just lack of heating, hot water or food that is the issue. It is the impact of these things that has a huge negative effect on my ability to keep myself and my partner safe and healthy, both physically and mentally. If one thing is clear, it is that financial hardship and poor health go hand in hand. People need to access financial help and be signposted to services that support their needs. GP surgeries would be an ideal place to do this. Thank you.
Hi folks, thanks for the opportunity to speak today. It's something that I'm really passionate about, and hopefully that can come across as I kind of explain what I'm going to speak about today. This goes back in Dundee. I'm the manager of council advice services within Dundee, but back in 2014 I was a welfare rights manager only, and I had worked in welfare rights for 33 years this year. And I've been a manager for about 24 of those years. And as a welfare rights officer, you get the opportunity to meet an awful lot of people. In my early days, you would go to tribunals, you would see people under stressful circumstances going in an environment that they weren't actually, comfortable with. They were very unsure as to what the process was going to be. They were in front of a judge. And they were extremely stressed. And that goes without saying that prior to that, they had been in financial difficulty, and that was the reason they were at tribunal. But by the end of those tribunal cases, if you had won the case for the customer, you would come out and you would see the relief on their face. You would see the fact that their income was going to increase and that stress would be taken away from them. And over the years, I saw that also we dealt with debt cases. And we saw people, the burden just lifted from them. And you could see that their health was going to improve going forward. And I slowly realised that a welfare rights officer's job was more than just, taking a person through a process, explaining what the law meant, getting their case together, putting it to tribunal, and hopefully getting a result at the end of the day. It was so much more than that. And that was really powerful. And I started to think, there's got to be a way where we're influencing people's lives here. And as a manager, for several years, we would write, as our specialist service often did, to primary care, looking for evidence on a person's physical condition in preparation for those tribunals. And for years, I had a little drawer by the side of my desk in my manager's office in Dundee. And there was a little file with a whole load of letters from GPs, basically saying how dare I write to them and ask for evidence. Sometimes they would give very short, pithy replies. But I kept them, and sometimes we got bills from GPs. So there was a culture clash there between welfare rights and primary care. So in 2014, I was on a Scottish Government call, and I knew by that point the stresses that GPs were under. So I saw the fact that, GP practice was in crisis. But I was on a call, and Kate Burton was on that call. And she mentioned just off the cuff that in Edinburgh, there was a practice that was providing medical evidence to welfare rights officers who were situated in practice. And all of a sudden I thought, right, this is where two different disciplines can come together collaboratively. So I'm going to speak a wee bit about partnership and collaborative working, because I'm exceptionally proud of the fact that you've got those two disciplines working hand in glove nowadays in so many areas across the country. And I think it's a huge, it's a huge positive for this country. Despite, the pressures we're under in terms of the cost of living crisis, the fact that GP surgeries are under so much pressure, that we've got two different disciplines working so well together. And just from Carey's presentation, a couple of things. A team that builds social inclusion. That is what we've got in Dundee in primary care now, and relationships of trust. So to give you an idea where we are, in 2014 that conversation took place and I was straight on it. I thought we need to work more closely with GP practices. And now, 9 years on, we're based within 12 practices within Dundee, approximately 90,000 patients out of a population of about 150,000 in Dundee. We take away those socioeconomic issues from health professionals, provide them with an outdoor and finish those conversations that GPs are perhaps in the past have been unwilling to have because there is no solution necessarily. There is no money that they can offer, but there's money that potentially we can offer through the skills and specialist work that we do. And it tackles income and resultant health inequalities head on. It's one of the reasons why I never want to be a social worker, because I see casework, continue, and there's never an end to it in my mind from what I see on the outside. Whereas welfare rights officers have got a real power, and money advisors also. They can take people through a process and get to a positive result at the end. But the one thing, the kind of key, like the MacGuffin in all of this, was the access to medical records. It was something that, the GPs were willing to give with the patient's express consent. And that, to me, seemed like a huge move forward from a welfare rights point of view, from an efficiency point of view, from being able to get the information to get the decision right first time, not have to go to tribunal, not have to even, get it right when you're actually making an application. And access to those primary care systems was crucial in that. It really was about embedding yourself in the practice. And from that, the whole idea of, it destigmatizes advice. Everything came together. It was a perfect storm. So we moved forward in Dundee in a kind of very iterative mode. We found a practice, the hardest thing. And the reason we found a practice was because our senior welfare rights officer knew the practice manager and had grown up with her, went to school with her. So she said, "That's a great idea. I'll convince the GPs. Don't you worry." And within a couple of months, we were in our first practice. We then went to the CHP at that time. And we went to Lucy Rennie, who I want to mention also, sadly passed a few years back. But Lucy was aghast. "Sorry, you get access to medical records? Well, I don't even get access to medical records." But we explained it to her. We explained the partnership working that was happening in Taybank was being raved about by the GPs, by Pascal Scanlon at the time. She said, "Right, I know where." And she provided us with a route map into most of the private practices in Dundee. She took us to meet practice managers. She allowed us to have the opportunity to speak to those practice managers. And from that, we ended up with, 3 practices where welfare rights are in. But I didn't want to stop there. Because in Dundee we work collaboratively with our voluntary sector partners in CAB and also Brooksbank Centre and Service. Lyndon and Ginny are here from Brooksbank. Ginny was totally on board with it when she heard it. She got it as well as an advisor, as a manager in an advice service. So we started to work in collaboration. So of those 12 practices, 4 are basically the voluntary sector doing it alongside us. We've got now 8 practices in welfare rights. And at that time, it was about fulfilling the poverty mitigation suggested to NHS boards, which I read, which came out in 2014. Secure household income, maintain a person's socioeconomic status, keep people close to the labour market, reduce household costs, and reduce barriers to services. That could be something that you could put on a welfare rights poster, basically. So from my point of view, it was obvious that we had a place within primary care if GPs would let us through the door. So we went through that, we tested it. Our overall attendance rate has remained relatively steady at 80%. And as you can see there, in 23-24, Post-pandemic, the service has been re-established as practices have reopened up to our services going back in. Our gains are up to 3.4 million, up 68% from the previous year. And we did the SROI with the improvement service way back in 2015, was it? I think 16 maybe. Maybe a wee bit later than that. And it recognised that for every pound spent on a welfare rights officer, you could get £38 back in terms of direct financial gain and up to £50 in terms of overall social gain across the services. Everyone liked it. GPs liked it. The health staff liked it. The welfare rights officers loved it because we essentially got to the right decision earlier in the whole process. And integration with the practice is the overall goal. So I'll just show you where we came from. This was the front page of the Courier in October 2014, and I kept that because that is how early on I was keen to try and get that link into health service. And from some of the stuff that that Kate has provided to us, you know, there's the benefits in terms of how the welfare rights advisor in practice helps team members in their role. It is about sharing two different disciplines, sharing knowledge and basically collaborating with each other and sharing that expertise in terms of what each other does. Shout out to COSLA, who were wise enough to give us a COSLA award for our work in Dundee. In this very building, we did a presentation, we brought down a member of the public who'd benefited from it, and that was kind of heartbreaking in the same way as the stuff that Carey had in her presentation, in terms of how we had transformed his opportunities by increasing his income. And it was probably the one decisive factor that we actually had a member of the public down to explain how it had been transformative in his particular case. And I just want to say that iterative process has been ongoing. So as we've continued to expand into the 12 different GP practices, I've looked for opportunities. We have, in the current year, got a couple of future plans to work with health on a more specialist basis. So there's a type 2 diabetes remission programme that's on the card, being run by NHS Tayside. That's recognised that we've got part to play in that in terms of trying to maximise income so that people can actually look to improve their diet after they've gone through a process of shakes and kind of support to try and lose weight as the first route to try and seek remission in their type 2 diabetes. And we're also looking to replicate the One Prescription Initiative, which looks to try and pay energy bills for those with respiratory and cardiovascular illnesses over the course of this winter. So having that open door into GP practice has been remarkable from our point of view. It fits the bill in so many different ways. And we also are now part of the furniture, as it would appear. We go to the regular cluster meetings, the 4 cluster meetings in Dundee. We give them an update on our services. We are effectively part of the furniture within primary care. And I love that because it is so effective and the outcomes are so beneficial for customers, ultimately. I love the fact that our officers walk into the waiting room in every GP practices and say, Mrs. Smith, and they could be a locum GP, they could be a dietitian, they could be anything. But the fact is they're a welfare rights officer. No one knows they're a welfare rights officer. That is so, so powerful. And I think, you know, going forward, being part of that mental health and wellbeing primary care group, we've got the opportunity to work with other primary care services, not just community link workers, the different mental health and wellbeing services that work out at primary care in Dundee. And that gives us a bit of surety as well. And it gives the GP surety in the fact that we are now part of that group. We've been here 9 years, and that's always a positive thing to tell GPs. You know, we're not going to come in, parachute in, and then disappear after 6 months. The funding is welcome. It goes, in Dundee's case, directly to Brooksbank to fund their services. However, without funding, we would still do this. And we've demonstrated that over the years. I'm 100% committed to this. And when someone asked me very recently what the thing I was most proud of in my career, I answered this project, because it has been absolutely phenomenal. There has been no negatives to it. It's been absolutely terrific. And one day, I hope, and we may well do this through the means of remote access to GP systems, which is on the horizon, I'm hoping that we cover every single GP practice in Dundee. We bring in more voluntary sector partners, and we provide a service which is the most efficient, the most outcome focused, and the best model that I think I've ever seen. And that's testament not just to the workers on the ground, but the people who have made it happen, to Karen, to Roddy, to Kate, to everyone else who's been involved in that process over the years. It's quite an emotional thing for me to see this grow and how far it's come in 9 years, and hopefully for many more years to come.
That was a super powerful and passionate speech there from Craig. I'm sure you agree. Now, I did promise you a video at this stage, but I'm going to take an executive decision and say that I'm not going to share the video. We've heard a few examples. Carey, for example, gave the 3-minute video and showing the impact or the problems, if you like, when the welfare advice service is not there. There's lots of good examples in the report that you're going to receive. What I propose to do is, when we go to the kind of comfort break, I'll put the video on in the background, but I'd far rather we had some time before we go into discussion groups to ask some questions. And rather than cut that short and squeeze in the video, I think it makes much more sense for us to have a chance to ask questions of our 3 presenters. Thank you all for your participation today. Also, thanks to the people at the improvement service, from the improvement service that were creating that information at the tables. I'll get back to you. Big thanks once again to our 3 presenters. I'm sure it was off to a great start at the start of the day, and let's keep the conversation going after lunch. Thanks, folks.